Good morning, everyone. My name is Judy Abrams, and I'm a past president of the Ovarian Cancer National Alliance. 16 years ago, I lost my best friend, Judy Mello, to ovarian cancer. To honor both Judy Mello and our friendship, her husband, Jay Schwam, established the Mello-Abrams Annual Lectureship, which supports our ability to invite leading authorities in the field of ovarian cancer to address this conference. Judy was first diagnosed with ovarian cancer in 1994 after having been diagnosed for breast cancer in 1986. She lived her life fully and courageously, without despair, and always looking forward, never back. She was also sustained by the love, affection, and support of her family and her many friends. But what allowed her to live her life as fully as she did was her amazing attitude, always positive and always looking forward, never back. She had this attitude until the day she died. She lived each and every day, guided by that spirit that she preached to one and all. Every day is a beautiful day. It's only the weather that changes. I am excited to introduce this year's Mello-Abrams Lecture, What's New in Ovarian Cancer Research, sponsored by GSK. Renowned ovarian cancer expert, Dr. Shannon Westin, will discuss what's new and on the horizon for the treatment of ovarian cancer. Dr. Westin is Associate Professor at UD/MD Anderson Cancer Center and focuses on developmental therapeutics and the use of biomarkers to predict response and recurrence in gynecologic malignancy. Dr. Westin.
Hello, everyone. My name is Shannon Westin, and I'm an associate professor and the director of early drug development and phase 1 trials in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center. And it's my great honor to be here at the OCRA meeting, giving the Mello-Abrams lecture. And what I'm really going to cover today is what's new in ovarian cancer research and treatment. And I hope we'll cover a large number of novel topics, and I'm excited to have some lively discussion with you, maybe at a future meeting. And these are my disclosures. So this is a very savvy audience, and you know that the treatment paradigm for ovarian cancer hasn't changed that much, although we've made some progress over the last few years where our patients will have their symptoms and have their diagnosis and either have a debulking surgery or neoadjuvant chemotherapy or some combination of the two. And we used to just move right to surveillance, but we're thrilled that we do have some nice maintenance strategy options now available for our ovarian cancer population. But ultimately, unfortunately, the majority of women with ovarian cancer are not cured, will have a recurrence with another potential surgery, chemotherapy, maintenance, rinse and repeat. And so what I'm going to try to do throughout this talk is really focus on these different kind of areas along the ovarian cancer continuum and what has changed and where we're making progress. So here are the objectives. We'll talk about some success, specifically focusing on Parp inhibitors for the treatment and maintenance of ovarian cancer. And then we're going to get into what's next. So we'll talk a little bit about anti-angiogenics, or agents that target abnormal blood supply, both early success as well as newer agents on the horizon. And then we'll get into some really novel agents like antibody drug conjugates and other novel therapies that I think are really going to be exciting to you. But first, let's start with Parp inhibitors. I think really Parp inhibitors came on the scene with their importance in homologous recombination repair. So what does that mean? What we know is the protein Parp can help repair single-stranded DNA breaks on our cells. And these happen all the time in response to sun or UV rays or anything, alcohol, such. So if we have Parp active, it'll repair those single-stranded breaks. But if we block Parp, and the cells continue to replicate, we'll see that these unrepaired single-stranded breaks are created into double-stranded breaks. Now, in a normal cell, these double-stranded breaks are repaired by something called homologous recombination. And that pathway includes agents or markers like BRCA1 and BRCA2 that help repair that DNA damage. But if you have a cell that doesn't have good homologous recombination repair, it's called homologous recombination deficiency, or HRD. If that double-stranded DNA break repair doesn't work, you can have genomic instability and cell death, though, so tumor-specific killing by Parp inhibitors. Now, there are other mechanisms of action that we've learned subsequently, but this has really been one of the primary areas. Now we know that Parp inhibitors can stick Parp to the DNA, so no matter what the aberration in homologous recombination pathway, it could still potentially work. Before I go too further, I just want to make sure we level set and we know kind of the different agents we're talking about. The 3 drugs that are currently indicated for patients with ovarian cancer are Laparib, Rucaparib, and Naraparib. And each of them have treatment and maintenance indications that we're going to talk about today. So let's go back to our treatment paradigm and kind of see where our Parp inhibitors fit in. First, we're going to go back to front because that's the order in which they got their FDA approvals. So first, let's start with second, third line treatment and maintenance. So this is a snapshot or a table that really shows the activity of Parp inhibitors and where we initially focused, again, based on that idea around homologous recombination deficiency and in the setting of BRCA mutations. And we saw a number of these different Parp inhibitors have really excellent ORR, which is objective response rate. That's shrinkage of tumor. This is much higher than what we would have expected for chemotherapy. And a lot of these trials were single arm trials that led to FDA approval, which was exciting and unheard of in ovarian cancer. Now, when we get these expedited FDA approvals, I feel like we're all kind of experts on this now with the COVID vaccines and such, but these expedited or emergency FDA approvals do have to be confirmed in a subsequent trial. So recently we had data from Laparib, the SOLO3 trial, that again was a confirmatory trial for that single arm trial that got the FDA approval. And this was in recurrent ovarian cancer. Patients had at least 2 lines of platinum therapy, measurable disease, and no prior Parp inhibitor. And they were randomized 2-to-1 to either Laparib or a physician's choice chemotherapy, weekly paclitaxel, topotecan, pegylated liposomal doxorubicin, or gemcitabine. And they continued on that to progression. Now, and importantly, many women had multiple prior lines, and over 50% had more than 4 lines of therapy. And what they found was that overall, Laparib was superior to chemotherapy. And that includes in response. So if you look over on the left, you're going to see these all throughout my talk, these waterfall plots. We want to see tumors shrinking. We want to see the water falling down these plots. So we saw beautiful waterfall plots for Laparib, 72% response rate as compared to 50% for chemotherapy. So clearly superior. And then on the right, that's a survival curve. And you'll remember you want a space between that. This is showing a difference in progression-free survival, or the time it takes for cancer to progress. And they saw a clear benefit to Laparib, confirming that FDA approval. Similarly, Rucaparib has been found to be active for patients with BRCA mutant ovarian cancer with more than 2 lines. And this is again based on response rates that approached 69%, as well as a wonderful progression-free survival. And that did lead to an expedited approval in May of 2017. And we recently saw data from the confirmatory study of this. This is Ariel 4. Similar study in that the patients were randomized 2-to-1 to either Rucaparib or standard of care. Interestingly, this study did consider if patients were potentially platinum sensitive or sensitive to a platinum agent, and patients could get a platinum-based chemotherapy. If they were considered to be more platinum resistant, they got paclitaxel. So a little bit stronger standard of care arm in the Ariel 4 study. And they wanted to be treated until disease progression, and they did allow crossover from chemo to Rucaparib. And the bottom line is, again, improved progression-free survival for those patients treated with Rucaparib over chemotherapy. So confirming that FDA approval for patients with BRCA mutations. But what about other people? The BRCA mutations is only in about 20 to 30% of patients if you include mutations in the blood and mutations in the tumor. So what else? What are some other things that might yield benefit from Parp inhibition? Well, we've seen that other aberrations or molecular abnormalities in pathway members of homologous recombination might confer benefit. So things like promoter hypermethylation or mutations in things like RAD51D and RAD51C. And it can seem like alphabet soup, but the point is we can start really teasing out these abnormalities to really understand who might benefit. And further, we're starting to learn a little bit about identifying people who might not benefit from a Parp inhibitor on its own. For example, cyclin E1 or so-called CCNE1 amplification has been associated with resistance to these agents. Now, we do have some commercial measures of homologous recombination deficiency available to us that we can order right now in the clinic. The majority of them look at genome-wide loss of heterozygosity. So how different do the different chromosomes look? And it may include other features such as telomeric allelic imbalance and large-scale state transitions. But ultimately, these different markers are put together into one score, and you get a positive or a negative. In some studies, this score has correlated with prognosis, so how well you do in general, and then some have potentially looked at it as part of a predictive marker for response to therapy. One of those studies was that same Ariel 2 study that we looked at previously with Rucaparib. When we move away from just the BRCA mutant population, you can see there's a so-called BRCA-like population. Response rates of 30%, progression-free survival of 7.1 months, not too shabby, not as great as what we see with the BRCA mutant population, but still pretty darn good. Now, and this is just another kind of depiction of that. This is those survival curves. You can see that top line are the patients with the BRCA mutation. That middle line is the wild type with homologous recombination deficiency. So both of those groups getting more benefit from PARP than perhaps the completely biomarker negative or wild type tumor. And interestingly, we don't have an indication for Rucaparib for this patient population, although it would indicate there's potential for benefit. Now, conversely, Naraparib was evaluated in a study called Quadra, which was a patient population. They had 3 or more lines of therapy, and they got Naraparib as a single agent, so a single agent study. And the primary endpoint was response rate, but they specifically weren't just looking at patients with BRCA mutations, but looking at an overarching group of homologous recombination deficient patients that had these HRD tumors. And what they found, again, nice falling curves on our waterfall plot, nice falling lines. And you can see the blue are the patients with BRCA mutation, but the orange are patients that had just homologous recombination deficiency without a mutation. So really benefit across both of those groups. It was about a 30% response rate, and that did yield an FDA approval for any homologous recombination deficient ovarian cancer and patient that had had more than 2 lines of prior therapy. So these are our treatment indications, and these are why we have them, okay? But what about if we've gotten chemo and we had a benefit and we want to have a maintenance strategy in the recurrent setting? So we have a number of studies that looked at this place. The first was study 19, which looked at Laparib as a maintenance option. This was a randomized study of 265 women who had a platinum-sensitive recurrence, got a chemotherapy, a platinum-based combination, either carboplatin with pegylated liposomal doxorubicin or gemcitabine or paclitaxel, and they had a response to therapy, either CR, which is complete response, or PR, which is partial response. And again, remember those curves. We want to be able to put at least our finger between. You can almost put your whole hand here. This is a nice big difference in progression-free survival. So there was a reduction in the risk of progression for those women that got Laparib as a maintenance strategy. And further, when they teased it out, they did not have HRD testing back when this study was published. They did have BRCA mutation testing, and you can see that the biggest bang for your buck really was in those patients that had a BRCA mutation, but we still saw some benefit in the patients with all comers. Now, this was interestingly approved in Europe as a maintenance strategy for patients with response to therapy, but in the US, they had to do a confirmatory study, which was SOLO 2. Now, SOLO 2 was very specific, and then it was only in patients with a BRCA mutation. Same otherwise, okay? So recurrent platinum sensitive, got their platinum-based therapy, had a response to therapy, and then got randomized to either the Laparib or the placebo. Primary endpoint was that progression-free survival, time without progression. And look at this, man. You could drive like a Mack truck through those curves. That is a beautiful difference. And a 70% reduction in the risk of progression with a Laparib maintenance in this population. And so using the data from study 19, which was all comers, and the data from Solo 2, which was in the BRCA mutant population, the FDA gave us approval for everybody. Anybody with a platinum-sensitive ovarian cancer that had response to chemo can get a Laparib maintenance. Now, we do have overall survival data, which is obviously the most important thing to all of us. We all want to live longer. And importantly, Laparib also yielded an improved overall survival for patients that got Laparib. And that's important because a lot of times we get into this discussion of sequencing, like, well, should I get it earlier or should I just wait for my recurrence? Should I just get my chemo and kind of avoid that maintenance option and get it as treatment? And this indicated that no, you shouldn't. You're going to live longer the earlier you get your Parp inhibitor. Now, the other two Parp inhibitors have similar studies. So you're gonna kind of be in a little bit of a second verse, same as the first situation here. So the other studies were NOVA, which was with Naraparib, platinum-sensitive ovarian cancer patient population. They could either have high-grade serous histology or a known mutation, and they had to have a response to their platinum combination. Now, this was actually two studies, one in the patients with BRCA mutation and one in the patients that were BRCA wild type. In both of those arms, they were randomized to either Naraparib or placebo, and the primary endpoint was progression-free survival. You can see that in both groups, mutant and wild type, still a great benefit. Perhaps a little bit more in that BRCA mutant population, where you're seeing about a 73% reduction in the risk of progression and a Mack truck hole in that Kaplan-Meier survival curve. On the wild type side, we still saw benefit though. We saw about a 55% reduction in the risk of progression and a not too shabby difference there. So showing that progression-free survival benefit in both groups. And that did yield an FDA approval for all comers in this maintenance setting. Now, when we tease out these groups a little bit more, right, because I'm telling you that we got the mutant population, we've got the HRD positive population, then we got the completely biomarker negative group. Like, how does this all look different? You can see that for those patients that had an HRD tumor, that they got the bigger benefit. You can see both the somatic BRCA mutations as well as those with just true HRD in the absence of any mutations had a pretty significant difference in their progression-free survival. Whereas as you get out to completely biomarker negative, you're starting to see less and less. And then finally, last but not least, was Aerial 3, which is assessing rucaparib. Similar study in that we're seeing high-grade serous or high-grade endometrial, 2 more prior lines of therapy, response to their last platinum-based therapy, randomization 2-to-1 to either rucaparib and placebo. And they did tease out a number of different factors, including genetic status. And what they found is, moving from left to right, biggest benefit in that patient population that had BRCA mutation, okay? Still very good benefit in that patient population that was homologous recombination deficient. And then in the all-comers population, still some difference, although when they teased out that completely biomarker negative group, that difference went down by quite a bit. And so very consistent results. We know Parp inhibitor maintenance is the real deal. And this is in second line, right? So what are we going to do? Because we're smart, we're going to move it up front, right? So let's look at Parp inhibitor maintenance in that upfront setting to really understand what that potentially can offer us as far as progression-free survival and hopefully overall survival benefit. So I wanted to kind of give you like a bird's eye view or a 1,000-foot view of the number of phase 3 frontline maintenance trials that have been reported up until this point. And you can see that there are 5 major trials that have been reported. Now, GOG 218 was a trial of bevacizumab that was reported, gosh, a while ago, like almost 10 years ago. Oh my God, I'm getting old. And so we can see that that was a group that was all comers. It was not directed by biomarker, predominantly stage 3 patients, predominantly minimal residual disease after surgery, and they were treated for 15 months. Then you've got Solo 1, Paula 1, Prima, and Velia, which all included Parp inhibitors. Solo 1, we're going to get into these details in a little bit, but looking at the population, Solo 1 was only in patients with BRCA mutation. All the rest of the PARP inhibitor trials were all comers. Okay. The majority of patients in Solo 1 were stage 3. For the remainder, pretty much everyone was eligible. And there were very few patients across all these treatments that had inoperable disease. So just to give us kind of an overview of these populations as we transition into our kind of drilling down and distillation. So first, let's talk a little bit about the Bevacizumab data, just to give us some context. And so we know when we're looking forward at these PARP inhibitor maintenance trials, what makes an impact. So GOG 218 was a study that was done in the States. It was in all comers advanced ovarian cancer. They randomized from either paclitaxel carboplatin to the combination of paclitaxel, carboplatin, and bevacizumab. And then further, patients either got a placebo maintenance or a bevacizumab maintenance. And again, that was 22 cycles. And you can see when you're looking at these differences, there's some difference. There was about a 30% reduction in the risk of progression with the use of Avastin, both with chemo and with as a maintenance strategy, but it wasn't profound. And so we could not, it ended up getting an FDA approval much later after this was presented and published, but it made a sort of a splash. Like some people adopted it and others were not as excited about it because when they looked at the difference in months, they just weren't super enthusiastic. I mentioned Icon 7, it was done concurrently, it was done in Europe. It only had a chemo arm versus a chemo Bev plus Bev maintenance arm. And you can see again, not a huge difference in the two arms, although when they teased out a more high risk population, they felt that was more impactful. So let's transition to the new data. So Solo 1, maintenance study upfront, okay, only in patients with Brca mutation, newly diagnosed, had their response to therapy after surgery and frontline platinum-based chemo, and then were randomized 2-to-1 to either Laparib or a placebo. And they got this treatment for 2 years. And that's really important because I'm going to call on this in a couple of times. So the primary endpoint was progression-free survival. And again, you could drive a Mack truck through this graph. And it's really, of course, very important to see not only that the reduction in the risk of progression was 70%, but the overall reduction in months was many. And then when we looked at secondary endpoints and specifically looking at the second progression-free survival, which again is getting at that idea of, can you instead hold that Laparib, like, let's not give it up front, let's give it later, we still get benefit. The fact is that no, patients that got the Laparib first did better as compared to those that may have gotten it later. And then the last thing I want to call your attention to is that, remember, here at the primary endpoint, patients got their Laparib for 2 years, and yet that benefit persists well after that, for years after that, in fact. And so that was really exciting because we really feel comfortable that we can stop the PARP inhibitor at 2 years and still get that benefit. Now, Palo 1 was meant to see if you've already started Laparib, or sorry, if you've already started bevacizumab, should you add a PARP inhibitor? Will that be helpful? And so this was, again, a newly advanced ovarian cancer who had gotten their surgery and then platinum-based chemotherapy with bevacizumab. And then the patients were randomized at the completion of their chemotherapy 2-to-1 to either Laparib versus placebo. And they continued the bevacizumab though. So there really wasn't a true placebo arm, and that the comparator arm was an active comparator. And you can see there was a difference in the overall group, in the all-comers group. There was an improvement in progression-free survival, about a 40% reduction in the risk of progression. But when they teased it out by homologous recombination deficiency, so by those features we've been talking about, those patients that either had a Brca mutation or were truly just HRD positive had the biggest benefit. Okay, so 70 or 67% reduction in the risk of progression. Those that were HRD but had no mutation, still really nice benefit. Okay, a hazard ratio of about 0.43, which means a 60% reduction in the risk of progression. And then, interestingly and kind of surprisingly and really quite sadly, the patient population that was completely biomarker negative didn't really get much benefit over bevacizumab. We kind of had expected some synergy there, so we were really surprised. But remember, this wasn't against a true placebo. People were getting that bevacizumab, so it's hard to know how that might have made things change. And of course, those of you that are savvy trial design women will say, hey, there was no Laparib only arm, right? Because one of the questions that comes up in all the time now is, well, if I was getting bevacizumab and I want to get the Parp inhibitor, do I have to keep going on the bevacizumab, or would I get just as much benefit from just the Parp? And we don't really know that answer from this trial. Now, another agent that has an FDA approval in the upfront maintenance setting now is Naraparib, and that was from the PRIMA study. Now, the PRIMA study is a little different from the two studies we just talked about. It was an all-comers newly diagnosed ovarian cancer, but it was specific patient populations that were considered to be at high risk. So what does that mean? That was patients with stage 4 or patients with stage 3 that had residual disease at their after their primary surgery. And so they were randomized 2-to-1 to either Naraparib or placebo. And again, we were looking at progression-free survival. And there was a difference in the entire group. So the all-comers population demonstrated a 38% reduction in the risk of progression with Naraparib. And that was persistent over 6, 12, and 18 months, which was impactful. And so when they teased out the biomarkers there, you can see that it did make a difference what the biomarkers were for each patient. So the best bang for our buck was in the population that either had the Brca mutation or homologous recombination deficiency, but Brca wild type. Those are where we saw the biggest benefit. However, even in those patients that are considered homologous recombination proficient or have negative biomarkers, there still was a 32% reduction in the risk of progression or death. So this got an all-comers approval. I think, really the jury's out. I think some people will give Naraparib to all comers. Some people will have a really kind of intense conversation with the patients about what's really your potential benefit versus the risk. And I think we're all struggling because it's so exciting to have all these great maintenance options. And we want to be able to offer that to every single one of the patients in front of us, but we really need to weigh what kind of side effects, what kind of potential complications, what's the cost, and really what's that potential benefit. So that's really where we are with these strategies. But just like in second line, Parp inhibition is here in the frontline setting, and certainly very exciting to see so many approvals for our patients with ovarian cancer over the last few years. Now, if everyone's getting Parp inhibition in the frontline, then the natural question comes like, what happens if we do have a recurrence? So one study that's looking at this, and we're really excited because I think we're going to get data for this in just the next few weeks, is the OREO study. This was looking at the use of Parp inhibitor after recurrence on Parp inhibitor. So what does that mean? These were patients that had a platinum-sensitive ovarian cancer, got their chemo, got their Parp inhibitor, and then ultimately had recurrent disease. So then they get put back on platinum-based chemotherapy. And if they have a benefit, this is 416 patients that they were able to accrue, they were then randomized to Parp or placebo. So the question is, can you do Parp after Parp? And they included two different groups. They included a Brca mutated group and a group that was completely wild type. So hopefully, fingers crossed, this is a positive trial because it'll really help us, because if we're given Parp up front, we want to know, can we still use all that great data that we have in the second line? So fingers crossed and stay tuned. So now what's next for Parp? It's almost like a dartboard. We're taking a bunch of really cool potential targeted agents and immunotherapies and anti-angiogenics to try to see how we can combine these agents to get better outcomes. Obviously we're happy with some of the responses and the benefit we've seen with Parp alone, but it's not good enough, because for patients that don't have a Brca mutation, that don't have homologous recombination deficiency, we need better strategies. And further, we know resistance can develop. Patients can eventually start losing benefit where their tumors figure out a resistance pathway and start to grow. So what can we do in this setting? So there's been a lot of exploration around the combination of Parp inhibitors and immunotherapy. Now, scientifically, the reason that we think this might be cool is that when we're looking at homologous recombination deficient tumors, they often have a really high neoantigen load and higher numbers of tumor infiltrating lymphocytes. So that should make them more responsive they're more easy to find for the immune system, potentially more responsive to immunotherapies. And when we treat patients with PARP inhibitors, it causes these little DNA fragments, DNA damage. And because of that, those little DNA fragments can induce what's called a sting response, which is an inflammatory response, which can make immunotherapy work better. And in xenograft models, so mouse models, we saw synergy. So if we gave PARP, it was okay. If we gave the immunotherapy, it was okay. But together, it was much more effective in reducing tumor volume. So these are the kind of reasons why we looked at this, or we are looking at these combinations. Now, to date, we've had a couple of studies get reported with some really interesting results. The first was the Topacio study. This was combining the Parp inhibitor Naraparib with immunotherapy called pembrolizumab. And you can see, again, I've taught you now, waterfall plots, lots of falling waterfalls. And those are both in patients with BRCA mutations, as well as those with BRCA wild type disease. So that was really exciting. And then on the right here, B is a swimmer plot. So that's how long did the patient stay on the therapy? And you can see these are in weeks. Some patients stay on over 100 weeks. So when it works, it seems like it can be really durable. So this is really exciting. And I just, again, wanted to highlight the fact that a good proportion of these patients had platinum resistant disease, which you would not expect to have a benefit from PARP inhibition, and a large proportion were wild type. So pretty exciting, and this is being explored further, and we're going to talk about that in just a second. Now, we've also seen the combination of Laparib and Dervalumab. Now, again, Dervalumab is an immunotherapy PD-L1 inhibitor, and this was in a trial called Mediola, where they looked at patients with BRCA mutant platinum-sensitive disease and saw a 72% response rate to the combination. Pretty good, although we have seen some single agent PARP that approach that, but still a pretty nice response rate. And again, looking at our swimmer, patients staying on for a long time, and a nice little waterfall plot showing reduction in disease. Now, when they teased out, though, in patients without a BRCA mutation, this is where things got kind of interesting. You can see that they looked at two different combinations. The bottom swimmer is Laparib and Dervalumab alone, and the top swimmer took Laparib plus Dervalumab plus Bevacizumab, that anti-angiogenic we talked about. And that was pretty cool because what they found was a better response rate and longer time on therapy for these patients with BRCA without a BRCA mutation. And if we kind of tease that out a little bit more, it really didn't correlate to that homologous recombination deficiency. In this study, they called it genomic instability status. That's the same thing, but they found benefit in both groups. So this is getting at that maybe we're starting to find a potential option for patients that don't have those biomarkers. So these are being explored further. There's a number of upfront studies that are now, I think, mostly completed enrollment, but we're waiting on data. So the first is the Athena Trial, where they're looking at the combination of Rucaparib with the Nivolumab, another immunotherapy agent, for maintenance in upfront ovarian cancer. The first trial, which was a combination of chemotherapy plus Bevacizumab plus Naraparib plus dostarlimab, which is a PD-1 inhibitor. So that's one of those 3-drug combinations that we just looked at in the recurrent setting. So will we see improvement in the upfront setting? Fingers crossed, it's a yes. And then I would be remiss if I didn't mention there's 2 different combinations in the upfront setting that are utilizing Laparib. So in the Duo-O study, we have chemo and Bevacizumab plus Dervalumab plus Laparib. And so similar to the first trial in that kind of 3-drug combination in the maintenance setting. And then the KeyLink 001 or the NGOT-OV43 study, which is just looking at chemo plus pembrolizumab, the PD-1 inhibitor, with or without Laparib. So very interesting studies coming out hopefully soon over the next few years. So we'll have to have another meeting where we can discuss the results of those data and how it's changed our practice. So this is a perfect kind of midway point. We're going to kind of transition away from our PARP inhibitor friends and move into some other agents that are looking really interesting and pretty exciting. So first, we're going to focus a little bit on anti-angiogenics. Now, you'll remember I mentioned anti-angiogenics are targeting the abnormal tumor vasculature and the tumor directly, something specifically called VEGF. And we've talked a lot about bevacizumab already and how successful that's been. And there's a number of other agents that have also been explored here. But first, let's level set. When we have a patient in front of us that has platinum-resistant ovarian cancer, the response rates to treatment are okay. All right, this is usually 1 to 2 prior lines of therapy. We see about a 20% response rate, which obviously when you're hearing that from my voice, you say, God, that is not that much, 20 out of 100 women, that's it. And we agree. Like, obviously we like to see some response, but we want more. And so that's really why we've really explored other options like bevacizumab. Now, bevacizumab as a single agent had some it was at least consistent with chemo, but it wasn't all that much better, which is why we immediately moved on to combining it with chemotherapy. I'd be remiss if I didn't mention some of the other novel anti-angiogenics which have already been explored. You can see, again, consistent rates like with drugs like Cedarinib or Cabozantinib, Pazopanib, which all hit these anti-angiogenic targets. So around 17, 24% response rate. So good, but not kind of practice changing for us. And none of those agents has really been explored as a single agent in ovarian cancer. However, we have seen a lot of benefit to combining bevacizumab with chemo. And this was the Aurelia study that was again done in patients with a platinum-resistant ovarian cancer. And we found that when we randomized patients to either chemo versus chemo plus bevacizumab, that it improved progression-free survival. Again, time without growth of cancer, which was really important. And even more importantly, this study did a great job and looked at patient-reported outcomes and found that even with the addition of another drug, so chemo versus chemo plus bevacizumab, patients felt better. They had reduction in their symptoms at baseline and after treatment. So really exciting data to show that the additional drug didn't impact quality of life negatively, and in fact, improved things markedly. So that is a standard of care and is FDA approved. Now we've got a number of really exciting new agents that are coming down the pike that I'm going to spend some time talking about. So the first is Navisiximab. Now this agent hits VEGF just like bevacizumab, but also hits something called DLL4. DLL4 is a member of the Notch pathway, and it's been implicated in resistance to anti-angiogenic strategies. And here on the right, again, these are curves looking at the effect of these agents in mouse or rat models. And the bottom line is when we see the combination of an anti-angiogenic like VEGF and the DLL4, it does better than either drug on its own. And in fact, even if we addressed it with Taxol, say we add paclitaxel, it's still that dual agent does better with paclitaxel than say bevacizumab alone or the DLL4 inhibitor alone. So really exciting data that led to several really exciting trials. On the left are the results from the single agent trial. This is just Navisiximab on its own. And again, response rate of 25%. Now, you might be thinking, yeah, Shannon, that's the same as what we've seen before. This is really exciting because these patients in general had 4 and 5 and 6 lines of prior therapy. So not the same old therapy group that we had seen some benefit for bevacizumab and other agents before. So even as a single agent, this is pretty exciting. And then on the right is a 1B study, a phase 1 trial where they combined the Navisiximab with weekly paclitaxel and found, again, look at that waterfall plot. You love that. Lots of tumor shrinkage. And importantly, that response was in patients that either didn't have any bevacizumab before, okay, but even more importantly, it was a high response rate of 33%, even in patients that had had prior bevacizumab. And again, this population had had a number of prior therapies. So this is exciting, and this agent is moving forward in a randomized phase 3 study coming near you, where hopefully it will change the standard of care. So fingers crossed. Now, VB111 is a really interesting drug, the very hard name. No, so it's ofneragine Obedenovic, and I'm just going to call it VB111, much easier. Thank you very much. This is a cool dual agent, which is actually a gene therapy that has a dual mechanism. It both targets the tumor vasculature, basically stimulates endothelial cell apoptosis or cell death, and that releases tumor antigens, and that elicits an immune response. And then at the same time as it's killing tumor cells and eliciting a tumor immune response, it also has an immune adjuvant. So it stimulates the immune cells. It increases T cell infiltration. Again, T cells are our fighting immune cells. So those get into the tumor and they transform tumor tumors from so-called cold tumor or non-immune tumor to a hot tumor. So you get this cool dual mechanism, all part of this gene therapy adenovirus. And this agent has shown some really interesting results early on, both as a single agent or in combination. You can see in combination with paclitaxel, the response rate, when you included CA-125, was 58%. So again, falling waterfall, very nice. And that's led to the GOG 3018 study, which is called OVAL. And in this study, they're randomizing patients to either weekly paclitaxel, which is the standard of care, or the weekly paclitaxel plus BB111. So it'd be very interesting to see how that might improve the standard of care. Now, moving away from anti-angiogenics, we're going to talk a little bit about some really cool different types of novel therapies that are on the horizon. The first are antibody drug conjugates. So these are really cool agents because, we know we could kill more tumor cells if we just gave higher doses of chemotherapy, but patients can't tolerate that. We have too many adverse events, makes people sick. And so we have to limit the amount or the dose of the chemotherapy that we can give. Well, antibody drug conjugates going to get around that because what they do is they take an antibody, which is something that's going to respond to a protein or an antigen that's sitting on a tumor cell. And we specifically pick some type of antigen that's not typically found on normal cells. So it's very focused on cancer cells. And then it has a linker and links it to a drug that we call a payload because it is a high dose drug, way higher than we could give you in your IV. And so you get these really high dose chemotherapies basically pulled into the cancer cell and it kills the cancer cell. So really cool idea. And we've seen a lot of different drugs that are in development and really look very exciting. I'm going to focus on just two of them that are arguably kind of the most developed, but there are a number that I think you're going to see coming down the pike over the next few years. So the first one I wanted to talk about was Mervituximab. Now, Mervituximab is an antibody drug conjugate that targets something called folate receptor alpha. So when you look at patients with ovarian cancer, the expression of folate receptor alpha is probably in about 40% of women of their tumors. Okay, so this study was, and there was phase 1 data that looked really, really good for Mervituximab, nice response rates, and so they moved into a randomized study, which was called Forward 1. And this again was in patients with platinum-resistant disease that either had medium or high folate receptor alpha expression. And they were randomized 2-to-1 to either the Mervituximab versus an investigator's choice chemotherapy. And that included paclitaxel, pegylated liposomal doxorubicin, or topotecan. And the primary endpoint was progression-free survival, because that's what we care about. We want people to live longer without their cancer coming back. And what we found actually was, you can see on the left, the intention to treat population, those lines overlap. Like, oh man, that didn't look that great. And then when they looked at on the right at the group that was dubbed folate receptor alpha high based on their testing, it wasn't that much better. So they didn't see the benefit in progression-free survival that they would have expected. So then they went kind of back to the drawing board and used an earlier type of scoring, which was called PFS2+. So it was a specific way to say, is the folate receptor high or not? And then when they used that rescoring, then they started to find a difference. And so they thought, gosh, we did design this trial wrong. We should have been more specific with our patient population. And so they have restarted a trial called Mirasol, or redesigned the trial and done a new trial where they're really being very specific about that, who's folate receptor alpha high. So fingers crossed, we can really identify the appropriate population for this patient, for this drug. However, they've also moved forward looking at the combination of Mervituximab with a number of different agents, including Bevacizumab, carboplatin, pegylated liposomal doxorubicin, and pembrolizumab. And they've published quite interesting data on the combination of Mervituximab with Bevacizumab. And this was reported last year at ASCO. And again, look at that. I don't need to tell you anymore because you guys are all experts. You like these waterfall plots, do you not? Even on the left, in those patient population that included medium folate receptor alpha expression and high folate receptor alpha expression, we saw a 47% response rate. So really high comparatively to what we've seen with some of those subsequent 3, 4, 5th line chemos. And when they teased out on the right, the population that had the high folate receptor alpha expression, it was up to 64%. And that was high even in the group that was deemed platinum resistant, 59%. So really exciting data that is going to be moved forward for patients. Another antibody drug conjugate, which has been really exciting, is called XMT-1536. And this one targets something called NaPi2b. And so the receptor is NaPi2b, which is highly overexpressed on ovarian cancer. And you can see here, this was a phase 1 trial, which was trying to find the right dose. And then once that dose was obtained, their plan was to move into patient population that had ovarian cancer. In addition, they were looking at lung cancer, but I'm not going to focus on that today. And what they found was there was a benefit. So in the population with ovarian cancer, they had a 35% response rate, including 2 patients that had a complete response. And that's really exciting because we usually don't see complete responses in patients that have had multiple prior lines of chemotherapy and that are considered platinum resistant. You know, that's unheard of. So these data really made us excited. Now, you'll look at the waterfall plot and you'll see lots of falling. It's not a big trial though. You're going to say, Shannon, there was only like 15 patients. And that's right. It was a small kind of cohort to start, but it was so exciting that they're now moving into a larger cohort to see if we can confirm this benefit rate and see if this is something that we can move forward. And again, you know, as a patient, your tumor may have response to, or may have expression of folate alpha, receptor alpha. Your tumor may have this NaPi2b. So we're trying to tease out these populations of, you know, who benefits from what agent and really focus that for that patient. Now, let's talk a little bit about a totally different target. This target is called AXL, and the drug is called ABB500. So AXL is, again, highly expressed in metastatic ovarian cancer, which is important. It binds to a ligand, which is called Gas6. And this Gas6 AXL pathway has been implicated in tumor or therapy resistance, so chemotherapy resistance or resistance to immunotherapy and other agents. So it seems to be a really important pathway. So ABB500 is a high affinity AXL decoy receptor. So what does that mean, Shannon? That means basically it binds to the ligand of AXL. So it blocks the kind of activation of this Gas6 pathway that makes tumors more resistant. And so you block this resistance pathway and you give this agent with chemotherapy, you can potentially see more benefit. And in fact, in early phase trials, they have. So they combined the ABB500 with either paclitaxel or pegylated liposomal doxorubicin, and they found it was safe. So of course, that's important. The adverse events were manageable. But importantly, they found a 41% response rate. So that combination of chemo with the ABB500 was very active. And so now we have a randomized phase 3 trial that is ongoing that's looking at weekly paclitaxel as a standard arm with or without ABB500. So again, fingers crossed that that's something we can move forward. And I would mention that it's really important to note that they're also looking at markers of response. So they have some ideas around things in the serum and things in the tissue that might predict a response to these therapies. Now for something completely different. This stuff is wild. There's a new treatment on the market that is called Tumor Treating Fields. And you can see this is the little backpack. And it literally, you stick it to yourself. It has these stickers that create these electric fields that exert forces on charged tubulin proteins. So it actually acts very similar to chemotherapy. Tubulin proteins are the target of a lot of chemotherapies like paclitaxel and such. So it disrupts the formation of the mitotic spindle and impacts the synthesis of the tumor DNA and causes cell death. This is not a new therapy. It is FDA approved in glioblastoma brain cancer tumors, both in recurrent as well as in the upfront setting in combination with chemotherapy. And it's also been FDA approved in pleural mesothelioma. And again, you can see you wear it. I think you wear it like 16 hours a day. It's like this little backpack, so you can still be functional and go, do your thing. And what we found is there was an early study which combined the Tumor Treating Fields device with weekly paclitaxel and had a really nice response rate of 25%, clinical benefit in 70% of patients. So clinical benefit means not only did they either had tumor shrinkage or their tumor stabilized, which again is really important. And the progression-free survival was much higher than what would be expected from standard of care, just chemo. It was reaching 9 months. So that was thought to be interesting enough to move forward into GOG 3029, so-called Innovate 3, which is randomizing patients to weekly paclitaxel with or without those tumor treated fields. And again, it's 18 hours a day. So you have to wear your little backpack. But the primary endpoint is overall survival. So we're looking to see, do these agents extend length of life? And then finally, you know, we're always limited in these kind of lectures. There's so many cool targets. And so this is by no means every single agent that you could cover, but I'm going to cover one more agent and one more target that I think is really interesting and shows a lot of potential. And that's WEE1 inhibition. So this is a cell cycle pathway. And what we know is that P53, which is aberrant in almost all high-grade serous ovarian cancer tumors, it modulates the G1S checkpoint. And so when we have a mutation in P53, the cell cycle becomes very dependent on another checkpoint, the G2M checkpoint, which is modulated by WEE1. So if your cell cycle gets stopped when there's a problem at one of these modulation checkpoints and it fixes its DNA, the cell continues to do well and, you know, multiplies and divides and no problem. However, if you have a problem at one checkpoint and you pass that checkpoint and it doesn't get fixed at the next checkpoint because that checkpoint's not working, that will increase what's called replication stress and can basically cause cellular catastrophe and death. So it's hurting the cancer cells specific when you block that WEE1 in the setting of a P53 mutation. And several of my colleagues have looked at this opportunity and specifically taking a WEE1 inhibitor, which is called adavosertib, and combining it with chemotherapy. And you can see it's been combined with both carboplatin, which many of you are familiar with, and gemcitabine, and found that with carboplatin, it was just a single arm trial, and they found a really nice response rate. Again, our waterfall plots are falling beautifully, 47% in a small study. And conversely, in the adavosertib gemcitabine study, they actually randomized patients to either the gemcitabine alone or gemcitabine with adavosertib and found an improvement in progression-free survival as well as a reasonable response rate. So these combinations are being explored further. Now, we had some data in our labs and in others that demonstrated that WEE1 might be an important marker to block in the setting of resistance to Parp inhibitors. And so we took patients that had a prior Parp inhibitor and had ultimately ended up with a progressive disease on that Parp inhibitor. And we randomized them to either get the WEE1 inhibitor alone or the WEE1 inhibitor in combination with a Parp inhibitor, Laparib. And bottom line is we saw benefit in both groups. For the adavosertib, or for the adavosertib alone, we saw a 22% response rate with a 63% benefit. And conversely, with the combination, we saw a 29% response rate, then 89% clinical benefit. And that was exciting in the all-comers population. But when we teased out the population that had no BRCA mutation, so again, our patients with a BRCA wild type, look at these response rates, 31% to WEE1 alone, adavosertib and olaparib, 39%. And look at that duration of response for the combination, 8.7 months, 8.4 months for the duration of clinical benefit, 94% of patients getting some clinical benefit. I mean, it was almost universal that those patients got some benefit. So this combination is super exciting, and to be determined where it goes forward. We're working out side effects and toxicities, but certainly exciting data to share for patients that may have developed a resistance to Parp. So in conclusion, thank you so much again for having me. I hopefully convinced you that Parp inhibitors are certainly here to stay for the treatment of ovarian cancer. But as we move these drugs and combinations earlier into the disease continuum, it's hard to know what that's going to mean for resistance. So we have to be thinking about these new novel therapies, how we sequence them. Certainly the new anti-angiogenics, antibody drug conjugates, WEE1 and AXL inhibitors are super exciting and are demonstrating some really neat results. But it'll be really important for us to really tease out those predictors of response and resistance that we were talking about, like who should get which of these therapies and how we can best improve outcomes for all of you. So with that, I thank you so much for your attention. Thank you for having me. And I look forward to seeing you all in person someday soon.